to have this presentation in an interactive mode. So, in case you disagree with me, in case you agree with me, please stop me. We'll have a brief discussion. Then, if the chairman agrees with this,
agree with the chairman.
All right, thank you very much. So, what we will try and do is leveraging public-private partnership, because that's the flavor of the day. And I do believe that the way forward in this country, whether it's health or otherwise, is public-private partnership. Now you all must be wondering that what is Additional Secretary Labour doing here in public-private partnership for health? And I must tell you a brief instance. When I joined the ministry here, someone asked me, where are you? I said, I'm in labour. He looked at me up and down. I was as thin as I am. And I looked fairly cheerful. And then I went on to tell him that I am not only am I in labour, I am also in pain. Because nothing happens in this ministry. By definition, nothing can happen in this ministry. Because if you deliver, you are out of labour. So you sustain that pain without delivering anything. It was in this context that this scheme came from nowhere. It came from nowhere because logically the scheme ought to have been done by the Ministry of Health. But they said they don't want to do it. I didn't realize why they didn't want to do it. It is only after 4 years of implementing the scheme that I realized why didn't they do it. How complex, intricate, difficult is the scheme. And they didn't want to do it. So we were asked to do it and we did the scheme. So the first point that I was mentioning to you, my experience in labour, there was this mandate by the Prime Minister of India. He said that there should be a health insurance scheme for the poorest of the poor in this country. And a group of ministers was set up, chaired by the Finance Minister. He looked at his own ministry, the Department of Insurance and Banking, and the officer sitting there said that, sir, we are already attempting to do a universal health insurance scheme, it's going nowhere. Then he turned around to the Ministry of Health. They said, we are already troubled with NRHM, there's a lot to be done in that. And they said they won't do it. The discussion came to a halt. So they wanted to catch hold of somebody. My minister was not present, I was deputizing for him, sitting in one corner there. And this is just an illustration on how some decisions get taken in the government. One of the senior officers said, sir, wo anil kar de raha hai. They were looking for somebody to be hung. So I stood up with folded hands and said, I don't even know what health insurance is. I have never had an exposure in health or insurance. How will I do it? No, it is for the labor. It was the workers of this country. I said, by that definition, everything should be with us. Every government scheme for some worker or other. No, decision taking. So I come back home, ask my wife, do you know what health insurance is? She said, I also don't know. So no one knew what health insurance was, and here is this ignorant man standing before you. My idea today is to learn from you. I'm so glad that I'm sitting amongst practitioners. I love it. Because the problem in India is, there is too much paralysis of analysis. Everyone knows the diagnostic part. And there are also some outstanding people who give the prescription in lovely documents. They will make speeches and then walk away. The practitioners are left with those documents of implementing those prescriptions. And the problem in this country is not diagnosis. The problem in this country is not prescription. The problem is implementation. And I'm so glad to be sitting with the actual practitioners on the ground. And as I said, I look forward to learning a lot from you. Now, when I was given this task of formulating the scheme after having spent, I think, 6 sleepless nights, on the 7th night, middle of the night, I was attempting to understand and get something out of health insurance. So I came up with 300 odd questions. The first question was, what is health insurance? And I kept on listing those questions because I didn't have the answers. And then we set up a task force to answer to those questions, and the answers became what later on came to be known as Rashtriya Swasthya Bima Yojana. But as we were evolving this concept, and the 3 points that I mentioned here are extremely important, because this scheme was for the poor, and this poor man was illiterate, he was migratory in nature. I tell you this because in India these are critical problems when we formulate the scheme. We do not look at the consumer, at least in the government's context. In the private context, you'll find out whether Aishwarya Rai will carry a better message or Hrithik Roshan will carry a better message. You do all sort of research to see what the consumer likes. In government, we don't do that. Someone has a bright idea, We come up with a bright paper, we find a bright officer, and we try and implement it brightly. It doesn't happen, that's a different matter. Until unless we look at the consumer, we looked at it. Now this man was poor. Consequently, the scheme had to be cashless. This was not a major issue because there were indeed a large number of cashless schemes in the country and elsewhere in the world. But the second point was very, very important. Most of these people to whom this scheme was attending were illiterate, and hence this health insurance scheme had to be paperless. Even today there is no paperless health insurance scheme in the world except the RSP1. So this was perhaps one of the biggest challenges before the scheme, to make the scheme paperless. And third is very important in the Indian context. The poor man travels from one place to the other in search of employment, and we can't tell him that, my dear friend, you don't fall ill when you go to the other state. The need for health insurance is more when he travels outside his own place of living. Is it correct? The vulnerability is much more. So the scheme had to be portable. Now, here was a huge challenge. No scheme in the government is portable. So if you are availing public distribution system, that is subsidized rates, you are tied down to a shop. If that shop is somehow closed, you had it. You don't really know what to do. Similarly, even an excellent scheme like NRETA, if you go out of your own village and go elsewhere, if you want employment, you won't get it. So none of these schemes in the country is portable, and we had to come up with a portable scheme. These were the challenges, and this in brief what the scheme is. Now, people keep questioning me that why do we have 30,000 as the limit? Why do we have 5 as the limit? Frankly speaking, at that point in time, ignorance was bliss. So we said we have to have some number, there was some scheme, somewhere we said 30,000. You know, in the task force, there was an expert, a World Bank expert, who we thought would help us. He was struggling with a tender for a health insurance scheme in a state for 3 years. And he said, no, I'll get you a tender document. The problem is that in all such cases, we look for perfection and it doesn't exist. Even today, there is no perfect health insurance scheme anywhere in the world. You always learn, you always improve. So after he couldn't get it, we said we'll go ahead with whatever we have. And fortunately, we didn't launch a pilot. You know, we are very fond of pilots, aren't we? Despite knowing that in India, literally and otherwise pilots don't fly. But you know, you have pilots after pilots after pilots. In fact, 2 years down the line, after I had implemented the scheme, the World Bank called me over to Washington. While making a presentation, I asked them this question, that have you ever evaluated how many of your pilots have flown? They didn't understand the question. I asked them, how many of the pilots have been replicated and scaled and to what extent? But we are very fond of pilots because we get a lot of funding for pilots. And everyone puts in every effort in it. That pilots sometimes fly, but others won't. Because you can't put in same effort elsewhere. So we didn't do a pilot, and this is what the scheme was. The second point was important, pre-existing diseases. If people who know about what happened in the US earlier, even they didn't have it. Now, in the new Obama policy, it is there. And this happened because we had some interaction with them. They wanted to learn something from RSP. I said, we don't have much to offer, but this is something which we wanted to offer. For us, it was more of a necessity than anything else. Why? Because if I am going to insure millions of people, there is no way that I am going to ascertain, in which I will ascertain whether he has a pre-existing disease or not. So purely for practical reasons, but this has become a USP under the scheme. Practically it will be implementable. Why we use the word implementable? Because sometimes what happens is the experts give you an idea which is non-implementable, and they will criticize you for not implementing what they said. In RSPRI, what we say is any expert who comes to us, any advisor, we tell them please walk with us. Don't only talk, come along with us. Because in our part of the country, I come from UP, there are people called Rai Sahabs. Rai, they give you advice. They give you a Rai and then they go away. And then you don't know what to do with Lalla called Rai. Because, you know, as practitioners as you are, as we are, you have to do things on the ground. I am accountable to delivering that thing on the ground. I can't walk away with a lovely document. Very shiny, lovely document which is discussed not in a seminar like this. Here we are discussing practices. I attend seminars, workshops, and I don't travel to bigger countries. I travel to countries like Ghana, like Bangladesh, like Nepal, like Indonesia. And there, sometimes, the ideas are discussed, and I hit it. I said, you give me an idea which is being practiced, which can be practiced, and which possibly you come and sit with me and do it. So this is briefly what the scheme is. It is a cashless coverage. I will spend some time on the provision of the smart card. There's some provision for 1 day prior to hospitalization and 5 days after hospitalization. The initial limitation of the scheme was that we limited the scheme to inpatient care. There has been a lot of criticism, but we did it deliberately and consciously because most of the insurance schemes have collapsed because of moral hazards. And it is virtually impossible to control moral hazards in OP care because the guy comes and goes and don't really know what has happened there. But now that we are comfortable with the technology that is being used under the scheme, recently a decision has been taken to extend RSPY and extend it for OP facilities also. It's a seminal decision. But it is only after we got the comfort. There is a small transport allowance that is given. Funding, 75% comes from the central government, 25% of the state government. In case of northeastern states, it's 90 and 10. Now, the fourth point is important. We said that we'll take 30 rupees from the beneficiary. All hell broke loose. And people are very fond of criticizing bureaucracy and bureaucrats. They said, you bureaucrats, you sit in the air-conditioned rooms. How do you think this poor man will pay 30 rupees? We stuck to our guns. We said, we know we will not compromise on this. And the explanation was very simple. You know, a large number of insurance schemes have collapsed because the beneficiary is not informed that he is covered under the insurance. So centrally, you have a press conference, a check is handed over to insurance company and says, this population is covered, and the guy doesn't know. How do you inform him? Take 30 rupees from his pocket. He will never forget that he is covered. Second, he will value. For him, 30 rupees is quite a lot. He will value what you are giving. Give him free and give him nothing, he will forget it. He curses the government that everything is free yet not available. So what is the purpose of being free? And finally, most importantly, since he pays 30 rupees, he can take me to the consumer court. I paid you this money and you have not delivered the service. So far, we are fortunate that no one has taken us to consumer court. But there have been statements that it's not free, we paid money, you better give us service. This is now one of the USPs of the scheme. The government is now toying with the idea of, including this sort of a fee. This is a fee, not a part of the insurance. Very interestingly, when we started the scheme, we didn't realize that a time will come when there will be a large number of people who will be prepared to pay the entire insurance premium to ride this platform. Today, I am sitting on such applications because they have actually found value in what is being offered. And these are the terminologies which I will explain to you subsequently are not actually spoken or understood in the bureaucratic parlance, value, marketing. This is something which the scheme is trying to solve. This is a typical smart card that is being used. You look at the chip there that carries the biometric data of all the family members. So clear identity. It is not. Why do we use smart card? Because there is a lot of talk about online systems because we still believe that a large part of the country is not connected to the backend server. So we have an offline data residing here. So one-to-one matching is done, biometric matching. It carries a credit of 30,000 rupees. So every time a person goes to the hospital. Now, how is RSPY different? Let me spend some time on this because this is something which is close to our heart because when we used to say it's different, people used to ask me, what do you mean it's different? Something which is not mentioned here. First thing was when I went to the Planning Commission and I said that we do not have targets in the traditional sense under the scheme. What do you mean? How can you have a government scheme without a target? Government scheme there has to be a target and there's another word in government parlance, monitoring. Without monitoring, nothing happens. And we are trying to demonstrate who are we to monitor? We are wiser than those people who are implementing. If I am able to convey a particular value to the stakeholder, I don't have to monitor it. My challenge is to convey that value. My challenge is to create that value. Now let me come to one of all these one by one. In our understanding, I think this is perhaps the largest ever IT application anywhere in the world in the Google settings. And let me explain this to you. For the first time, this smart card is actually personalized, printed in the village, handed across the table. It has never happened, it is not happening elsewhere. And this has been possible because of the technology that we are using. And mind you, we have issued 32 million smart cards, more than that, and not a single card has been issued to a wrong person. Making that statement in India is quite a statement. How does it happen? On the spot, there is a government officer who is also given a card by us. His biometric data is in his chip. He certifies through his smart card that the person standing in front of the laptop camera is the one whose name is appearing on the laptop. He puts in his smart card, he puts in his thumb impression, the signals from his card flow to the card of the beneficiary, only then the beneficiary card becomes valid. And I also know who's the officer who certified it. It's non-repudiable, I'll hang him if he certified a wrong person. So hence, 32 million smart cards absolutely to the right person. There are other problems with this scheme which I'll share with you. So, and not only that, when a person goes to the hospital, he has only to match his thumb impression, it's matched, or there is also a photograph in this chip. Photograph can also be seen. He's admitted in the hospital, a particular procedure is put off, amount deducted. Now, deduction of the amount or access to this chip is available to only those persons to whom another card is issued by us. It is only when those keys are inserted can he access this card, and only then can he deduct, and we also know who has deducted the amount. So this is actually using technology at the lowest level. But to me, I think the biggest positive of this scheme is, the biggest USP of this scheme is empowering the poor man for the first time. First ever time. What is empowerment? Choice. Earlier, he hardly had any choice. He had to go to a public hospital. Good, bad or ugly, whatever it was, I'm not passing a judgment or a comment on that, but that's the only place he was available. Today, this man can walk into any of the empaneled hospital, public or private, right through the country, and he carries a credit with 30,000 rupees. We have more than 12,000 hospitals empaneled right from length and breadth of the country. He can walk into any of these hospitals, and hospitals welcome them. Why do they welcome them? Is the third point. It is perhaps the first ever business model for a social sector scheme. That's the point that I was making in the planning commission. That here, we don't have targets for the insurance company. Why? Because we pay to the company an amount as a multiple of the number of smart cards that they issue. They have to issue the smart cards. And mind you, they can't issue to a wrong person. So I don't have to push them on the targets. They will issue as many as they can because they get money. So I don't have to push them, I have to only facilitate, create conditions wherein they would do what they ought to do, and if they have a problem, they come to me. So I don't have a problem, the scheme is an autopilot mode. I attend these conferences and the scheme is happening. 75,000 cards being distributed in the villages as I talk to you per day. That's how the scheme is done. Similarly in the hospitals. Many of you are running these hospitals. Maybe some of you are not empaneled, or most of you are not empaneled as part of a hospital. Maybe we'll become good enough for you to be attracted to this scheme and this hospital. Maybe that's my hope. You will join in, become a part of this journey called RSBY. I'll come to that later on. So this is a business model also for the hospitals. Because we guarantee payment to the hospital within 30 days. And today, almost 98% of the claims are being settled within 30 days. How does it happen? It happens because every day this data flows from the hospital to a server, insurance company server, and everyone knows from on which date this data is flowed. The clock starts then, and within 30 days, insurance companies have to give me a certificate that there is not a single claim pending for 30 days. We are guaranteeing. Now I'm comparing it to the scheme in Ghana. Excellent health insurance scheme they were running. Collapsed. Why? Because they didn't know how to settle the claims. We have digitized most of the operations. This is digital data on the basis of the claims go back. And now Ghana sent a huge delegation, 20-member technical delegation here. They are using some of the technology that we use here for claim settlement. Then we have a very robust key management system, some of which I pointed out, how the card is issued, how it is used in the hospitals. This is a very secure key management system through which we ensure that only authorized persons have access to the data. Because this will help us in future also, because recently we've taken a decision to convert this card into a health card. And there are some ethical issues as to who should be allowed, how access should be allowed to that data. This will help us, the security system. This scheme is extremely complex on the back end. I remember one of the chief secretaries wrote to me, Anil, who's going to use these complex gizmos called smart card. There are 11 sets of software that are making this scheme happen. But then I don't even know what those software are. I don't really know. I shouldn't know. For the user, he has a card, goes to a hospital, thumb impression verified, gets his treatment, cuts out, that's it. For him, it's very simple. And it's so very different from normal government schemes where the scheme is very simple for us and extremely complex for the beneficiary. Poor man has to run from pillar to post to get anything. He gets here, we have to really slog it out. The guy he's the king. And the validity of the smart card for all. This is a typical set that goes to the village. It gets into a laptop, there's a printer there. This printer costed about $3,000 when we started the scheme. Today, it's being manufactured in India. The costs have come down, it's $1,000 now, manufactured in India. First recipient, probably overawed by the equation, doesn't look very happy here. He was indeed very happy. Overawed by the fact that he had a photograph on his smart card. He had actually found a physical identity. These guys don't have one. This is where we started in a very, very small way, experimental projects, and this is where we are. 32.4 million smart cards have been issued, about 110 million people covered, 4.3 million people have already gone to the hospital and received benefits. There are 12,100 hospitals. Andhra is in pink color, it will go green very soon. 1st of November, that we call the last bastion. Tamil Nadu is doing its own scheme. I am hopeful that, as in case of Andhra and other states, they will gradually realize that RSPO has value for them and they will join us. I have absolutely no doubt of that. It's just a matter of time. Now, what are the initial trends? There is certainly an improved access, and I have a slide on that, providing healthcare. I think the most encouraging development is the public sector hospitals improving. And how is this happening? You know, under the scheme, the claims amount from the insurance company goes to the hospital and stays there. It doesn't become a part of the government exchequer. Now this money, 25% can be given to the doctors who visit, doctor and his team who attended to the patient. So there's an incentive to the doctor to do what he ought to do in any case. Now in the morning we were having great discussions about this, so many people and so much money. That's not the problem in this country. I don't think money or doctors are a serious problem. The problem is doctor is not available there. I come from a state where I can confess and say that you go to a PHC randomly, you won't find a doctor. It's not that he's not posted there. He's doing some other private practice or something else. No aspersion on the doctors per se, but that's how we live. The doctors don't do what they ought to do. So the real challenge is, yes, do find trained doctors. But how do we push them to rural areas? How do we evolve in a manner that they feel incentivized to be where they ought to be? That's the real challenge. The problem, if you don't identify the problem correctly, you won't have the solution. By merely pumping in more money, 1% instead of 1%, you put in 4, 5%, and assume that healthcare will improve in India, I'm sorry, I don't think that will happen. We'll have to find out to what use that money is being put to. Where is it going? What are the real problems? And the real problem today, at least in a large part of this country, is doctors not available. It's not doctors not posted. They are posted, but they are also not. Of course, there is a shortage of doctors, no doubt. But at least those that are posted should be there. They are not there. We have to indulge in that. And that's where the RSPY is changing the scene. Today, in a couple of states, I went there, and the doctors told me, some people also told me, sir, your scheme is having a very negative impact. Now the hospitals are only looking after the poor. They are neglecting the others who come to them. What could be better than that? Because the doctors are incentivized to, you know, some of the public hospitals have created RSPY wards. They are not as good as Apollo hospital wards, but fairly good. Fairly good wards, and they have special treatment for RSPY patients there. Why? Because doctor gets. I don't know whether that is a solution. I keep telling everybody, RSPY is not the answer to the healthcare problems in this country. No, please. Unfortunately, it has been positioned there and it is being criticized that it is not. We never said that it is an answer to any healthcare problem. We are just doing a small experiment. If it works, it will show the way in a different way that how public-private partnership, public-funded and public-private operated scheme can actually do wonders in this country. Then, the third point is very interesting. This is the only scheme that has penetrated Naxal areas. Our teams were abducted actually, kept in captivity. The Naxals understood the scheme. He didn't have a PowerPoint like I have here, but they were told about the scheme and they found the scheme that way. Because everyone wanted healthcare, whether he's a Naxal or not. They left him, and the last statement that team told me was, "Theek se karna varna goli maar denge." And they did it. 70% enrollment in Naxal areas, 60%. It's amazing the way it is happening in the scheme. It is happening in the Northeastern. One of the very few schemes that is actually thriving in Northeast area. The finest performing states are not the traditional states. They are Chhattisgarh, they are Jharkhand, they are Tripura, they are Nagaland, Mizoram. These are states that are doing wonderfully under the scheme. Many of us don't even go there. Okay, now the fourth point, I have a small slide, I'll run through it. Women are benefiting more than men. And it's a very interesting thing. You know, recently there was all this spate of news items that RSPY has started hysterectomy cases and there are all sorts of things that are happening. I went to the state and I discussed, I sent a central team. You know, sometimes we tend to kill the messenger. Because earlier, even now, apart from RSPY, there is no data regarding various processes and procedures in the private hospitals, even in the public hospitals. There's no ready data. In RSBY, every day I know what is happening in which hospital, which procedure. And not only do we know, we let it known to be everybody. So there is this messenger telling them that a huge number of hysterectomies are happening. But I don't really know whether in the normal course how many hysterectomies are happening because the data does not exist. So you kill the messenger. You say it's because of RSBY it's happening. So we did a sample study and we found whereas in a few set of hospitals, of the 32 hysterectomy cases, 7 were from RSBY and rest were from other cases. Now this is not, I don't want to generalize it. What I am trying to say here is, please set up our data systems to understand the nuances. In some of the states, because of this data flow, they have been able to prevent epidemics. Because daily they have 6 cases of encephalitis, it keeps coming in, the data comes in. And you can actually take immediate action, which some states are doing it. Now the scheme is already gone beyond BPL. Earlier, to begin with, it was only for BPL, and as I said, there's disease profiling. There's some charts. The access to healthcare under RSBY is gone much beyond 2.7 as it's indicated here. It's almost touching 3% of the people. Whereas if you look at the NSSO data for poor, the access was only about 1.7. The hospitalization ratio, as awareness levels grow, the hospitalization is going up. And the most interesting part is females are outnumbering males over a period of time, and it's happening pretty fast. I'm rushing through this slide because I'd like to leave more time for discussion. Now this is an interesting case which I showed to government hospitals. One government Taluka hospital got ₹1 crore in 8 months from this scheme. And those doctors are like private businesses. They won't let them go to a private clinic. They will say, you come here, we treat you well. It's quite amazing the way public sector hospitals are getting this money. Now there is a flexi fund available to them. There is a guideline there, so they improve the infrastructure of the hospitals. They don't have to wait for the approval of the government or the finance ministry to sanction. You know, in government hospitals, you have an X-ray machine, there is no electricity. By the time you get a generator, the X-ray machine is gone. So there is, I mean, those who have worked in government hospitals and I've interacted with doctors, they feel frustrated. They want to do things, but they don't have the equipment. Here is a possibility to get that. Now, this is what I have said. Look at what happens in media and evaluation service. Now, I don't think there is any government scheme with a satisfaction rating of 70 and 90% across. No government scheme. And in surveys after surveys, we find the satisfaction rating ranges between 70 and 90%. Now, this is not to say that everything is okay with the scheme. I'll share with you what are the problems with the scheme, and we share it very openly. We'll look for your guidance on how to improve. But nonetheless, and you know, it surprised me because I was trying to understand why is it so. And the answer that came to me was that probably they were not getting anything. Now they got something, so they're being satisfied. The real challenge will be over a period of time. And this is the satisfaction rating in all Chhattisgarh, Himachal Pradesh. Look at the media. This is a very interesting thing. The first ever media item was in Wall Street Journal when World sat up to look at it. And I have a saying for this, you know. When yoga becomes yoga, it gets to be recognized in its country of origin. That has happened to RSBY. In fact, I was very lucky he mentioned it. I was very fortunate to be in company of people like Sam Pitroda, Vinod Rai, being nominated as one of the policy agents by the Economic Times. But this happened long after this recognition had come internationally. So Wall Street Journal called it one of the finest schemes then came in India. The Times of India said it. Business outlook. This was an interesting, and they had a foresight. Today, the smart card that I showed you is going to cause a revolution in this country, and I'll tell you how subsequently. Hindu, normally very critical India today, media has been pretty kind, except for very recent coverage on hysterectomy cases. By and large, they've been kind. I remember showing this, I thought I would show this film to you, but I haven't got it. A small 6-minute clip. Normally, BBC is very critical of these development schemes. So they said that it's a winning model, and when I showed it to my minister who had just taken over, I showed him this BBC film. So he asked me, "Aapne banwai hai kya?" So I told him, BBC ke to Prime Minister bhi nahi banwa sakta film. They have been. And 2 weeks ago, Economist came up with an excellent video on what this scheme is doing. International agencies have also been kind. The World Bank calls it a model for good design and implementation. This scheme is now going to at least 6-7 countries. As I said, I don't travel to the European or the American continent. I do travel to African and the Asian continent, assisting these countries to implement the scheme. Bangladesh has taken its decision in principle to implement it. Pakistan is already implementing a variant of RSBY. I was in Nepal 2 weeks ago, and they are planning a scheme like this. Indonesia, Cambodia, Vietnam, Maldives. Ghana, Ethiopia, all these countries now, they're sending delegation. Every month we have a delegation internationally coming here to see what is happening in India. In this scheme, they're very fascinated with the way things are. I don't think many people gave this scheme a chance, and that was a good thing about the scheme. Because had they given a chance, they would have expected a lot of the scheme. They didn't expect anything, we probably delivered something. Bill Gates Foundation is now associated itself with us. UNDP and ILO picked it up as one of the top 18 schemes in the world. And some people have doubts about the scheme, so here's this slide, because the President herself announced in the joint session that the scheme will be going to 7 crore families, will translate into 350 million people in the country. That's the future. This is also the future. We started with below poverty line. Now the scheme is gradually going up. Number of other categories have been included. As I said in the beginning, I am sitting on a large number of applications from groups that want to ride on the scheme to pay the entire premium. And that's I think, the essence of the scheme. If government gives the entire subsidy, what is the big deal? You know, I get a smart card, I take the smart card. I have to pay only 30 rupees, I pay 30 rupees. But the true test of this scheme is whether people like you and I are prepared to pay the entire premium to ride this platform. And that's the most satisfying part. Now, the other thing that is happening is, we started with secondary care and part of tertiary care. The scheme is going now to primary care. As I said, a decision has been taken. We'll move very gradually because people would want to jump. They say, this scheme is done, but do this, do this, do this. You know, either something. In India, this is a very interesting thing. Either you do nothing or you do everything. There's nothing in between. And I keep telling them, hold your horses. This scheme is gradually going up. It's very difficult. Insurance is very difficult. You know, even smart card is very difficult. I still say now, there is no other public-sponsored smart card project functioning in this country. They are all pilots. I don't know how many of them will fly. This is the only, and when I say 32 million smart card project, I think smart card service providers are having the future of RFPI smart card, and this is very interesting, nothing to do with healthcare per se. But I think this will revolutionize what is going to happen. This is a common data that is going to be stored. RSPY is already there. We have already taken a decision to convert this into a health card. There are some issues there. But this is going to be the game changer. In a paper that I wrote in the Economic Times about a year ago, I had used IMM data to establish that the country will save 20,000 crores of rupees per annum if this smart card is used for PDS. And I'm glad to announce here that on the 1st of October, I'll be right to issue the first smart card for PDS. It will have both RSPY as well as the PDS, and it will also have life and disability cover. So, Dr. Reddy, life cover decision has already been taken. We got delayed by a few months because there were other platforms being considered by the government. I won't name them. But this smart card has actually happened on the field. So gradually the departments are wearing around. And I'll give you a small example. A very small experiment conducted in Chhattisgarh revealed that the offtake of kerosene through this card was only 10% of the usual offtake. The rest of them being pilfered. The arbitrage in kerosene is absolutely amazing. 15 rupees to almost 40 rupees. So that's the arbitrage. So Petroleum Secretary himself wanted that this card should be used. So this experiment will happen in Punjab, whereas the Grace experiment is going to take place in Chhattisgarh. I think that's the future. Now we are also in discussion with the Ministry of Rural Development. They want this smart card to be used in lieu of the job card because it's absolutely foolproof. In fact, we'll be able to, through GPS system, we'll be able to locate that person on the spot. He can't sit at home and get his 100 rupees that he gets. So it's going to be very interesting. This is going to be the future. These are some of the recent developments I mentioned to you. We did experimental projects on OP. We got some good learnings, and hopefully we'll extend OP care also. We are discussing with the Department of Financial Services to use the pension, to this card for pension. PDS, I already told you, these are the countries that are trying to do it. We set up an organization called NEST, wherein we are trying to assist other countries to do this scheme. These are the questions that I leave you to you. We'll have, why are the Apollos and Maxes not getting their hospitals and panels under the scheme? Don't they have a mandate to serve the poor? Yes, indeed, they have. Let's enter into a dialogue. Please come on board. We'd like to learn from you. There are a lot of quality issues that we'd like to learn from you. I request you to please join in this group. If there are any problems, we'll sit down and discuss. This RSPY has benefited from discussion. We don't claim that we have the wisdom. We don't. In fact, I am one of the most ignorant persons sitting here talking in terms of health. Each one of you would know much more. But it is this partnership between people like you and us that RSPY is what it is, and hence I would request these hospitals to have a dialogue and see how we can learn from each other. Because see, what baffles me is that both Apollo Munich and Max Pupa are part of RSBY as far as insurance is concerned. So if the scheme is bad, why are you there? And if this scheme is good, please come on board. Please provide these services. I'm sure I've had some very interesting discussion with Dr. Reddy, and I'm sure, and she's very willing. I wish I had spoken to her earlier. Probably I wouldn't have had this slide.